Hello, everyone. Thank you, Milton, for that introduction. I just give you a little bit of background of me. I've been in the telemedicine industry now for, 8 years, and prior to that, I was on the medical imaging side of things, where PACS systems were new technology and really considered telemedicine back then. And now we look at PACS systems and teleradiology as a standard. It's not, we don't even really consider that telemedicine, and I really think that's the way this telemedicine is going. It's going to be just common practice at some point. So a little bit more about my background. I was more on the vendor side. I've worked for companies like MedWeb, VitalNet, and Air Methods, and more on the business development side and on product development. And I came to work for Health Navigator because I felt like there was something missing in workflow. There's, as you all know, telemedicine has many different flavors out there, and I really like the workflow piece of that, and this gives some kind of evidence-based clinical content to workflow. So thank you again, Milton. Let's see. So the talk today is that there's so much buzzwords out there about artificial intelligence. What is that really? I mean, I want you to think about a few things as what actually defines AI, how can AI improve telemedicine, and then are patients actually ready for AI? And let's see, give me 1 second here. So, does the mouse work on here? Just to do this? No?
To the next slide?
No, to do this. No? That's okay. That's okay. I got it. So right now, we're not ready for AI in the true sense of what true AI is, right? So we're already doing narrow AI, which that's where you use Cortana, Microsoft Cortana. You're using Siri and things like that that will help you schedule with your schedule and then make restaurant appointments and that sort of thing. That's considered really narrow AI, and that's using natural language processing to do that, which are pieces of AI. There's also something called Open AI ecosystem. I don't know if you've all heard of that before, but last year is one of the top emerging technologies, and that's really using big data, also using social awareness, and then just having all these different algorithms that are based, that's part of AI, but it's not a true AI in the definition of machine learning. So we have companies out there today that are using health bots. One of our customers is Microsoft, which I'm going to showcase in just a little bit and what they're doing with the health bot. And I mean, I was on Skype the other day and I noticed there's one, Cardia, I think is what it's called, and it's just an app that's right in there, a health bot that you can utilize. So patients are using it, but it is a narrow-based AI, and it's always going to be, at this point, help with decision-making and that piece of it, not replacing the doctor, of course, until I'm sure at some point there'll be a little bit more of that, but we're not quite ready for it. So what we have today is, evidence-based clinical content is really going to help patients with this whole AI concept. My company, Health Navigator, is exactly that. It's evidence-based clinical content, and what does that actually mean? It's it's more about information. It's more than it's workflow, but it's really vetted clinical wisdom. This is years and years of research of over 80 physicians, other clinical staff members, and then using data from the CDC and things like that to actually pull all this together. And this is really developed to make like symptom checkers, diagnosis symptom checkers, and then also for telemedicine companies to be able to utilize in a way of rapid medical history, using natural language processing to take that patient's 5th grade literacy level, and they talk a little bit about what their symptoms are, and then take them through a rapid medical history based on what their symptoms are, It can also help on the provider side and decision support, and then clinical documentation support as well. So, you know, who is Health Navigator? Why do we do this in the first place? We really felt there needed to be some sort of standard out there. Coming from the vendor side of telemedicine, you know, I've worked for a few companies that, of course, we all try to do the workflow piece of it, and you use 1 or 2 doctors to do that, and you know that 1 or 2 doctors, you know, there's different opinions out there, obviously, on what that actually is. So Dr. David Thompson founded Health Navigator, but his background, his undergrad was in engineering and then became an emergency medicine, internal medicine doctor. So he's also the author of adult telephone triage content with his sister company, which some of you may have heard of if you have anything to do with call centers, Schmidt-Thompson Clinical Content. It's utilized in about 90% of the medical call centers in the US and about 50% in Canada. So with that being said, there has always been this need for this evidence-based clinical content for more in a digital format. So a little bit further into this, and think of us really as more of a back-end algorithmic engine that can power existing platforms. So we don't develop software. We will never develop software. All we are is content, and we work with companies such as MD Live and other companies like that to give them this capability to have that evidence-based content there. But it really works from a chief complaint all the way to the final diagnosis. But we have some partners that we work with that are more, they may just use our natural language processor because they want to be able to get that coded chief complaint for the patient and then be able to triage them or just to even prioritize the patients and who they should see first. So here's a quick look at like some of the people we work with. We don't just work in telemedicine. We also work in consumer engagement. And so in consumer engagement, we may work with them to develop a symptom checker or diagnosis symptom checker. In the telemedicine space, a vendor may use us on the back end as a way to gather information about their symptoms, rapid medical history, and that documentation support piece. So a couple of these up here, as you can see, ER at home and also MD Live or telemedicine companies we work with. Someone like Clear Triage is more on the nurse call center type space. So we work, it can help in direct consumer and then also in the space of a nurse assisted thing or a medical assistant or even just service agents that are answering a call. And I'll go through you know, a little bit more of this, but we really do have these co-development clients that we work with from beginning to end to implement. So I want you to think a little bit about the medical encounter, because in a telemedicine sense, whether you're just doing video or not, there's still, you know, a beginning, a middle, and an end to a medical encounter. And I'm not clinical. I'm really just a techie wannabe, and I love the whole clinical aspect of things. But like my founder says, there's always a beginning, there's always a middle, and there's always an end to that. So imagine, you know, the last time you went to the doctor, that's what happens there. What are your symptoms today? Then we're going to ask and drill down a little bit more of what's going on with these symptoms and more of that medical history and social history. And then finally getting into what is a possible cause there or a diagnosis. So that's what this slide is showing, just a little bit of, you know, that beginning piece being the clinical concepts and natural language processing, where we can take that patient's lay-term symptoms and them saying something such as the word barfing and then turn that into an actual medical terminology as vomiting and an ICD-10 or SNOMED code. And then from that, take them through these templates that actually relate to what those symptoms are. And that's taking, you know, multiple symptoms together that they can basically walk through that process. And then in the end, in a telemedicine sense, you may not want, you know, to use the diagnosis piece, but then again, you may want to be able to rule out those possible causes and the likelihood and for help with differential diagnosis for the patients. So this is a video I'm going to show right here, so it should be starting. This is just the natural language processor. utilized in a demo. So hopefully you can see that. Yeah, I hit my head and twisted my ankle, and I have been barfing and feel dizzy too. So what that's going to do is then it's going to take in gender and date of birth and for help with acuity. Then you're going to see over here on the right, it's going to pop up with the actual medical terminology for it. So there's, head injury was obviously from I fell and hit my head. Twisted my ankle became an ankle injury, dizziness, and then vomiting. Some other things to take into account are if a patient, let's say a neonate patient is in, and the acuity ratings are going to change if they have dizziness. Dizziness would not actually show up on a newborn, because how do we know that the newborn is actually dizzy? So it takes into a lot of account all of these sort of things here. But you can see the acuity ratings on the left, and we do the ICD-10 and SNOMED code. So this can follow throughout the whole encounter. It can be sent back to an EMR through a CCD. So some of our clients just utilize this piece of it and nothing more. So you can kind of piecemeal this out. So I'm going to give you a quick look at one of our customers here that we use NurseWise. So some outcomes. They were using customer service agents to answer the calls, but these customer service agents did not feel that they had enough training, obviously, because they're not medical staff. And a lot of their red flag rates that would go immediately to a nurse, they were 39% of all calls coming in. And this is 250,000 sick patients or parents of sick patients a year. So this non-clinical person assisting ended up, 39% of those calls were going over to a nurse anyway. And of course that backs up some of that, the waiting there for the patients. So all they did was implement our natural language processing with their own software, implemented the NLP, and then that basically went down to 14%. And that's because they felt like what those medical codes were coming back, and they knew if they needed to escalate that or not. So this is another one here. ER at home is utilizing us in a different way. So for documentation support. So over on the left, they've built two apps using our clinical content. But the left side is where they use NLP, and the coded chief complaint is output as a CCD that can be sent to a local EMR, so that they already have what that coded chief complaint is for the patient. And then on the right side, it's showing how a physician can utilize our content more in a SOAP note format. So this is because, working with co-development clients, you can have that look and feel however you want for the patient. We're just giving you that content, so you can develop SOAP notes and different things like that with it as well. So our largest client so far is Microsoft, and they are using us. They're more in the consumer engagement side. So they're utilizing all of our content in their HealthBot. Their Microsoft HealthBot technology, it's just an easier way for patients to interact with their doctors or insurers there. So these bots, or any bot that you develop with this, are really highly configurable by partners, and it can exist also by utilizing other data. So I'm about to go through this with them and show you how Microsoft has worked, but they're going to be utilizing other data as well. So this one should start here. So this one may not be as easy to see. My leg hurts. They're here in this bot. It's going to take data, and can you confirm who you are? Yes, and this is all user consent. So, and then it's saying, it's actually giving them questions here on where the actual pain is, where did it start, and they can pull data from Health Vault, and let's say that this patient is utilizing a wearable device or something like that. So it can actually take that data if they've connected it to there. So you've had recent injury, they're answering no. Health Vault data says this, you've taken this medication, is this correct? You worked out 12 minutes this week. So it's just taking different data like that, and this is where I was talking about AI being in a little bit more of an open ecosystem and utilizing that data there. So on this case, it's referring them to their nurse line, just because of that. So there's many different ways that everyone's using this, whether it's telemedicine, a nurse line, or just a triage and where they should go and what, and they do a telemedicine visit or something like that. But this is, this is really that full view of how an open ecosystem would work. So a couple more demos here. This is going to be a triage symptom checker. So, in more of a triage sense. So this is the natural language processing again. So describe your symptoms. So again, a patient just typing in their own plain words, I've been barfing and have the sniffles. So it's going to take both of those and a fever. So nose discharge is from sniffles, vomiting. They're going to choose that. We're not showing the ICD-10 codes, but that is on the back end. Here's more of that rapid medical history. Tell us more about each of these symptoms. How bad is it? When did this happen or start? The second symptom being fever. What is the fever? Then other symptoms here. And all this is really pulled from those coded chief complaints. So, and you can see the acuity ratings beside them and the color coding there as well. So now we're going to get, here are the specific symptoms. And you can tell we're not actually requiring them to answer everything. Our clients may require it, but we don't require it on the content side. So recommended care there is for the patient to go see the doctor. But there are triggers that can happen within telemedicine platforms, and what classifies them is able to see that. Thank you. Okay, just a couple more real quick. This one here is also the diagnosis symptom checker, so it's going to start off the same, but I'll quickly go through this hopefully. So it also takes common misspellings, vomiting, and have a fever, so vomiting is obviously vomiting, and have the sniffles, so something similar here, but what's going to be different is it's going to take them through a little bit more, more on the diagnosis side. So again, it's going to ask these specific questions here. So fever, and then if there were more, you would also have a couple more tabs there that would show through. So other symptoms, there's going to be a little bit more questions because we are trying to get to a diagnosis or a possible cause, and we're not claiming to diagnose again. This can be on the back end and be really for differential diagnosis. Okay, so now it's going to give us an output here, possible causes of what this would be, the likelihoods at the top. So this is more on the side of a physician being able to see this. They can look at emergency possible causes, all causes by alphabetical order, or just going back to top causes by likelihood. So all of this, being that it's clinical content, is going to be able to be shown to however you want to see this. So sources of care, which sources of care can this patient go to? That could actually be seen by the patient. Specialists, what specialists take care of this? And then internet resources here. This could be for the physician where he wants to be able to have access to PubMed references and just vetted internet resources that have, we have over 25,000 different resources that have been vetted there too. Okay, so let me move on. Oh, and I'm sorry, one last thing here. There's a summary, so it shows a summary. This can be emailed or printed. That's all data there. And then going into another possible thing is aftercare instructions, because what do you do afterwards, after you've had this visit? You want to have, to be able to share those aftercare instructions to your patient. And this one's just choosing diarrhea, for instance, and it's going to take you through, and here's a treatment. But we also have a capability of only sharing bits and pieces of this. So there's not just a full data dump there. Okay, so I'll move on since I'm out of time. So how did we get here? Like I said, research over 15 plus years. We did a large literature review and looked at large data sets, looking at the CDC reason for visit classifications. Over 80 physicians, nurses, dentists review the content, provide input to us. We've done benchmarking of call centers, of telemedicine visits, of ED visits. Last month we ran through 4,000 ED visits from where we knew what the chief complaint was and then knew what the outcome was, ran it through our diagnosis symptom checker, And then by that is just continually testing that and going through and getting that data there. So are we ready for AI? You know, it's not true AI, and no, we're not ready for true AI, but we are already using narrow-based AI in this AI ecosystem. So it's only going to continue to get better. We're not going to replace the doctor. It's just meant there for help, right? So anytime soon, at least. So thank you for letting me talk, and questions?
Thank you so much. I think we have some time. Any questions?
Thank you, Amy. That was really fun to witness. I have two questions. I didn't understand in some of the patient intake query, is this all based on voice, or is it mostly click choices by the patient? And then my second question is, at least for my work, we're largely in chronic care, and I can understand how this would be a little bit easier to algorithmically address. But there are some fundamentals to chronic care data acquisition from patients that would be very welcome by the clinicians in my workspace. Do you have any ambitions to try to address that need?
Right. So your first question then, yes, it can be used in voice. It can be used in the patient typing it in. That part doesn't really matter. Right now we have it where, you know, so long as you, and especially now that we're working with companies such as Microsoft and those sort of things, and using it, you know, if you want to use it with Alexa or something like that, that's coming. But right now you can actually just use the microphone on your phone and actually use that within your own platform. The second question being more of the chronic side, we do some of that. It's not specialized to that, so it's more based on symptoms. But you could utilize like the natural language processing piece to at least prioritize those patients on what their symptoms are and things like that. But there is some of that in there. It's just not specific to, you know, chronic care.
Any other questions?
I'm just curious, now you're taking the system out there, do you take all your inference data and validate them so you can add them to your training data, or are they separate?
Yes, but I think I know what you're saying.
Yeah.
So you're asking if we just validate it, that it's actual...
Right, because for example, if you ask a bunch of questions, your question might distort the answer, so you get data back that may not be valid, right? So how do you validate if the answer you get good enough so you can use additional training data to improve your system?
Oh yes, so we get triggers all the time that come back to us and show what the outcomes were, and then constantly tweak the natural language processor and things like that. Is that right? What I'm answering?
I'm just curious how you validate those answers and make sure they...
Oh, so we medical review boards,
Okay, so
we have different, yes, so we have...
You go through the whole process.
Right,
okay,
right.
Great, thank you so much.
Thank
Amy,
you.
for the great talk.